Hello everyone, we present our second small lymphoma talk, and today Oleg Akilov, our director of the Lymphoma Clinic of Excellence at UPMC, will talk about treatment and management of patch stage of mycosis fungoides. So,
pleasure to be here.
Mycosis fungoides is the most common type of T-cell lymphoma that we see overall in our clinics, and probably any dermatologist at least once in his or her life saw this condition, and we all know how to treat, but of course there are a lot of things to learn from an expert. And mycosis fungoides has various presentations. We just will talk about the most classical, most common presentation, which is a patch stage of mycosis fungoides. So Oleg, how to differentiate mycosis fungoides from eczema? To me it's always a challenge, and this concept of parapsoritis, small plaque parapsoritis, large plaque parapsoritis, how relevant is that to the diagnosis of mycosis fungoides? I know you have a short presentation to show us, and would you mind to talk a little bit?
Absolutely. So it's a huge question, right? This is what we spent, in our specialty clinic. This is what our residents trying to learn over 3 years, so it will be a little bit challenging, right, to put it in 2 minutes, but we will try. So first of all, mycosis fungoides has very peculiar presentations. Usually appears in patients who are around 63-year-old with slight female predominance, and has quite a peculiar look. It usually likes places that's hidden from the sun, right? So frequently we call it sun basing trunk distribution, right? So it's buttocks, it's a lower back, it's pretty much never in the face if we're talking about classic presentation, patch MF. And if you look at, let's press over here. No, it's not over here.
Yeah, we just have to go to our screen, and here we are.
Yes, so look at those patches. What's so striking about it? First of all, they're not scaly, right? So a lot of people think that they're super itchy. They're actually not itchy that much. Maybe 3 out of 10, right?
It probably depends a little bit, right? What is the person and how maybe spread up.
But still, I cannot recall a single patient who would come and say like, oh my god, this is the worst itch ever. So if you have patients like this, it's probably not MF, right? It's the worst itch ever. It's probably more eczematous, it's more
like
probably allergic contact, exactly. But those patches has really minimal edema. They're not really erythematous, right? Color over here a little bit bluish red, and look almost like a parchment appearance of the skin, right? I'm looking like a little bit on the side, looking at the slides. Contour not very well defined, right? Color a little bit off.
Other pictures?
So there's different variants, of course, besides classic. Sometimes there's follicular accentuation, especially.
And it's interesting how mild they could be, right? So sometimes they are hardly visible, and especially in people of color, I think you need sometimes to turn patient to different light and to understand that it's something going on, right?
And that's the reason why, frequently it's been overlooked and patients being not treated for several years and several years past.
And then there is this like very I would say confusing concept of parapsoritis, right? And some people use this word, but they don't know what they're using it. What is the correct use of this term, and what's your personal attitude to that?
Sure. So parapsoritis, it's a very descriptional term. I like this term, and I think it's important to kind of organize it, right, in your head. And then I think it's going to be crystal clear. So I adopted this table from Shelley from 1992, and I like his idea how he separated it in several different entities. So there is a Plevine PLC, right? That's everybody kind of like accepted that it's a variant of the same
entity,
right? But still kind of like on a spectrum of the same process. One is acute, another is chronic, and you can push them under umbrella for parapsoriasis gutata, right? When there's two different variants of psoriasis, parapsoriasis on plaques, small plaque and large plaque. Small plaque, it's not psoriasiform condition at all, right? It's a spongiosis on path. It's this fingerprint-like dermatosis on the flanks. Very distinct look and very distinct color. It's almost like a baby color, baby deer color, foam-like color. Large plaque psoriasis, different entity, and this is, I think, where confusion come from, because by definition, right, it should be large, so more than like 5 centimeters in diameter. Lesion frequently uniform, unilateral, and usually alone. So if you biopsy that spot, you may have a little bit of interface and a little bit lichenoid infiltrate. And some people even can see some features of mycosis fungoides, right? So this is when people start getting confused. Is it MF? Is it part of MF? Is it large plaque psoriasis? So on and so on. So currently it's a waste basket where we put all cases that didn't fit diagnosis of MF completely clinically and histologically. And on those patients we usually sit, right, and monitor, because some of them can progress. And I have cool slide that's we're gonna show the difference and who exactly gonna progress. There's two other variants of parapsoriasis, poikiloderma vascular atropicans. This completely reaction pattern. It's not a disease on its own, and I'll show a slide about it. And there is a retiform parapsoriasis or parakeratosis variegata, which is pure variant of mycosis fungoides.
Well, that's why I hate this term and try not to use it, because for me it's very confusing. I kind of I'm a little bit more like a polar person. I want something to be MF or not MF and try to give it a name, avoiding this parapsoriasis term, but I think it's more like a personal preference.
Well,
or not, right?
I am a splitter. I like to have names for everything, and I think if you keep it organized, it's easy. So
yeah, but just to keep important that large plaque parapsoriasis should need probably a little bit more monitoring and
absolutely
kind of seeing patients more frequently, right, and maybe taking biopsies.
Well, let's look at the slide, because there's some clinical variants in large plaque parapsoriasis too. This is an example of retiform parapsoriasis or parakeratosis variegata funa. This patient had patch plaque MF on the back, so this is just a variant of mycosis fungoides. We talked about pleva, PLC. I don't think we need to spend a lot of time on it, nothing special about it. Small plaque parapsoriasis or Brock's disease, this is the color that I was talking about, foam-like color, right? So lightly brown, very distinct color. Nothing else looks like this, and nothing else looks like that on the flanks, right? When you have almost like digitate projection of the patches, like somebody slap their finger against the flank of the person. Usually it's a middle-aged man. Sometimes there's a predilection for guys in this disease. Although, still, I would suggest to biopsy it, because you can be tricked. Right. Yes, because sometimes there's a variant of small patch mycosis fungoides on the flank that you may confuse for small plaque parapsoriasis. So it's easy to distinguish histological. This is spongiotic. MF is not spongiotic. So, and this is the example. So this is a guy, and you see there's tiny little patches, right? Mm-hmm. Not quite digitate, right? But you can stretch it. But color, look, color is very, very different, right? There is no baby color. This is more reddish bluish, right? And yes, in fact, that was mycosis fungoides. More over. Later on, patient presented with classic patches, yes, on the buttocks that he originally didn't have. But I want you to say a couple of words about large plaque psoriasis we start talking about, right? So it's very important to distinguish large plaque psoriasis with poikiloderma and without poikiloderma, because large plaque psoriasis with poikiloderma, a lot of people think this is MF. This is 100% MF, and nobody gonna convince otherwise. When without poikiloderma, those patients needs to be monitored, and only like regular patchy method can progress into different stage. The same with large plaque psoriasis. Sometimes in 10% later on in life we can find classic features of mycosis fungoides. And my favorite is anteriotoderma perstans, right? This yellowish hue patches. It's a slightly separate entity. Do we have anything else here? Nope.
No, I think that's, biopsy and clinical observation is very important. And then we also have other tests, that can help us in making a diagnosis, such as T-cell gamma rearrangement and clonality and monoclonality. So sometimes it's helpful, sometimes not, right?
Yes.
Which situations you find it helpful or not?
So for cases like large parapsoritis, when infiltrate is scant, right? You may not have enough templates, to generate a decent clonality map. So it may be tricky. So negative diagnosis in this case, it's not exactly.
Right?
Just technologically, it was difficult. And usually our molecular pathologists are very good. They write very clearly that we couldn't, just because template wasn't enough, not because of not enough T lymphocytes.
And then I think also it's important to know that people with MF may have other eczematous presentations on top of the MF, right? It could be allergic contact dermatitis. So even if a patient has known MF, sometimes they may develop unusual rashes in future that do not correspond lesions of MF. So sometimes it's important, even in a known person with MF, to confirm other lesions with biopsies and even compare clones, right?
Absolutely. Particularly young doctors sometimes think that's one patient, one diagnosis.
Yeah.
Right? And it's kind of silly to think, because in real life we all can get a bunch of different skin processes and different localization. So don't forget about it, right? So if a patient was diagnosed with eczema or MF, don't assume that's another lesion exactly like this. If it doesn't fit classic presentation, think broadly.
Do you perform any examinations and workup in patients with patch stage of MF? And if not, then when is that kind of line when you start thinking about more aggressive treatment?
So for patch MF, we usually don't go beyond regular workup, malignancies screening, age-appropriate one. So there's a notion that if patient with that are close to 10% of body surface area involvement may have some spillage in quotation marks into the blood, and for some of those patients, flow cytometry may be indicated. I usually not big fan of it, because even presence of couple cells in the peripheral blood, and fortunately our technology allow us to find even couple cells, would not change the management. So sometimes I want to save patients and insurance money and not do that, just because I'm not going to treat them differently.
Yeah.
But some people advocate for it.
Do you palpate lymph nodes at your clinical exam?
Absolutely, yes, certainly.
And
full physical exam, whole body skin exam, lymph nodes, absolutely, yes.
Any other exam perks, so to say, which areas you look for?
So certainly know your lymph node examination, right? Especially head and neck area can be tricky, not that easy to palpate. So go back to medical school, right? Find good oncologist. That's very handy tip. Find a good oncologist, ask them to show you once, just to refresh. They're excellent in doing that. Because if you're gonna find a palpable lymph node that's more than 1.5 per NCC guidelines, you need to do excisional biopsy and evaluate. Now they're trying to replace it. Now they're thinking maybe FNA is going to be sufficient. So it's an issue of debates among experts. But still, don't forget that sometimes if you get monomorphic rash, right, that's look more popular than patchy. PTCL sometimes can lurk under clinical impression of mycosis fungoides.
Yeah, so we'll talk about histopathology a little bit more in details in the other part of the lecture. I just want to learn more about clinical management from Oleg.
But again, if you have patients with couple patches in symmetric distribution under axilla, let's say, and you palpate it and all lymph nodes enlarged, right? This is probably not MF. Right? This is probably peripheral T-cell lymphoma with secondary skin involvement.
Yeah, that's also very important to understand.
Absolutely.
And we know how to treat early MF, so it's basically UV light therapy, it's topical steroids, right? What else? What is new in the market? Well,
there's mecloretamine gel that's called Valclor. It's old-fashioned nitrogen mustard that's now formulated in a gel. So that works very well. A lot of patients loves it because some patients feel like they don't have specific treatment, right?
Exactly.
Their local dermatologists already tried steroids. It's work,
So.
Yes, they already tried lights. They need something special. So it's very special stuff.
If there is any side effects, I personally just had a couple patients using it because of different difficulty to get from insurance sometimes, and sometimes it's not enough because the tube is small, so it's hard to cover the whole body area. So somehow I didn't find it helpful, but I don't have so much patience as you do, Oleg.
Right.
What are the side effects?
Patience is very, very important. So before we go into side effects, I want to say that company is super supportive, right? So there is very good support group, and what we usually do as physician, right, when we have to guide the patient to educate, over here actual company takes a big care, so they can do paperwork, they can educate patient, and they can monitor how many tubes patient needs and how they apply. I usually bring patient back 1 month after I start this medication just to check that they do everything correctly. So the main side effect is irritant contact dermatitis. Sometimes it can be nasty, it can ulcerate. For that reason, I usually start it very, very slowly, maybe twice a week only. So kind of think about it as a 5FU for actinic keratosis, right? So you can jump, you can create tons of inflammation quickly, you will still get the cure, but patient's going to be miserable, and probably you're going to be miserable when patient going to call you 100 times a day. So ease them out, right, in it. So start earlier, get them comfortable, get them acquainted with the medication, then you can escalate when they know how and what. So tell them to be their own doctor, in quotation marks. They usually love it. They're usually very responsive. Give them triamcinolone to overcome inflammation, right, after Valchlor, and everything's going to be fine.
Any perks about light therapy?
Light therapy is useful, particularly it's useful for patients who live far and they can get home unit. So I found it extremely helpful because this disease is going to be treated for quite a while. Let's be honest, probably 2-3 years, right? Maybe you need 8 to 9 months to get to remission, and then you need to continue maybe once a week to maintain, the effect of therapy. Usually, I like natural sunlight. So in summertime, I encourage people to go and get some tan.
With sun protection, of course.
Well, not for the face, right? Since we don't have lesions on the face. But only morning sun, right? Before 10 o'clock, 10-15 minutes, only 3 times a day on the backyard. Since, lesions usually hidden, right? It's usually in the buttocks. It's hard to run butt naked even on your own backyard. Usually, neighbors not in favor of this kind of activity. So there is a tanning through swimsuit that our patients can purchase.
I didn't know about that.
Yeah, so this is a good hint, good trick. So there's a website they can go. It's all very modest. It's nothing crazy. And yes, and getting this swimsuit under natural sunlight if, there's insurance barrier or they cannot come to clinic and get it.
Are you just using UVB light in your practice?
Mostly UVB, yes. UV works not that great. We keep UV for PUVA, right? Also, I don't remember last time when I used PUVA, honestly, because narrowband UVB works as great. And
you don't need to give anything.
Exactly, and liver, is not being damaged by oxazolone. So, yes, narrowband UVB usually I'll go to.
Do you go to anything beyond topicals and light therapy in patch mycosis fungoides?
So sometimes, and this is when, body surface area more than 10% when patients move into stage 1B. You can add something. You can add interferon intramuscular at home. Patients usually tolerate it very well. Usually it's not necessary, to be honest with you. But again, when body surface area more than 10%, you can start see expansion into the plaques, right? And some people start advocating, especially if these transitions happen quickly, maybe it's time for systemic systemic therapy, something like bexarotene.
Do you think it can prevent progression, or
no? Probably not. But because if it's already happened, it's already progression, right? So like what we're preventing, but we can still get the disease in remission and maintain it over there. Because if you miss this point when disease became 1B, right? You have couple years, and then it's going to progress further. Because 1A progress probably in 10%, but 1B progress into tumors in 20%. So it's still small percentage, but
it's still already every fifth per patient, so it's quite significant, right?
Exactly.
Well, thank you, Oleg, and we'll meet you next time to discuss more specific management for later stages of MF, and maybe we'll also discuss some unusual forms of MF, and I hope you like our small lymphoma talks. We are waiting for your feedback. Thank you.
Thank you.